Dr. Tino Pena joins us now. He is an interventional radiologist with the Miami Cardiac and Vascular Institute with the Baptist Health Group. He recently spoke at the Cayman Heart Fund Symposium on advances in cardiovascular risk assessments and therapies. Thanks so much for joining us.
Thank you. Thanks for having me.
So in talking about risk assessment and therapies, is there a lot of focus around prevention?
I think prevention is the most important thing. You want to make sure that if you can prevent disease from occurring, then you don't have to deal with treating it. I think the best treatment is prevention.
In terms of risk assessments, what's new? What's happening?
So we're seeing a lot of data and studies being done and being able to tease out which patients are going to be at higher risk for certain conditions.
Okay.
So what I spoke about was two different conditions. One is pulmonary embolism, which is the risk where you have blood clots that go to your lungs, and that's something that can be quite lethal. And we have the standard therapy, which is anticoagulation or blood thinners. And what we looked at is there's other risk predictors that may help us decide which patients are actually higher risk, may proceed to mortality or death in those next 30 days, so that we can aggressively treat those patients.
And it's, I imagine, one of those things where you're trying to find the balance between what's the right intervention and not, it's like you don't want to smash an ant with a sledgehammer.
Correct, that's
Okay.
exactly right. So exactly for pulmonary embolism, a very common disorder, 300 to 600,000 cases in the United States a year. When you see something like that, you don't need to treat all of them aggressively, but being able to find that 15% of patients that may actually progress to mortality or death and have a bad outcome. If we can treat those and prevent those patients from having serious consequences, then I think that's the right thing, and that's what we're trying to do in that disease process.
So pulmonary embolism, what's the other that you're looking at?
The other, we're looking at cardiac risk assessment.
Okay.
In other words, preventing heart disease and hopefully getting an idea of where that patient's risks are to make sure they're on the right medication so we can prevent them from having events, whether it's heart attack or strokes.
Okay. And are these, sometimes when we're talking about the heart, we're talking about electrical and plumbing. Are you looking at both of those things?
So here we're looking at really the plumbing. We're looking at
okay.
the arteries. So we have a CAT scan that will take a very quick scan. It takes 3 to 5 seconds. You take a breath,
Wow.
you hold your breath, they take the pictures, and we want to look at calcium in the arteries, in those arteries that go to the heart muscle. That calcium really basically represents hardening of the walls of the artery, almost plaque, or may call it atherosclerosis. And by determining how much of that calcium you have, we have an assessment of what the risk of you are having some type of cardiac event in the future.
What are the different therapies that are available for intervening and kind of, preventing a future event?
Right, so looking at prevention, we really talk about risk modification.
Okay.
You look at not smoking,
Lifestyle.
controlling your blood pressure, healthy eating, routine exercise program. But then we also look at things like your cholesterol and figuring out how low should your cholesterol be. And we have medications such as statins. We kind of decide whether you should be on those cholesterol-lowering medications and to what extent. And this is really where we've seen this type of examination, the calcium scoring examination, very helpful. So we have a patient that may have no calcium in the arteries. Those patients are probably okay without needing to be on those statin medications. Well, if you have a patient, again, on the borderline, you have no other reason to start them on the statin, on the borderline, but the patient does have some calcium, you may say, we're going to treat you with the statins. So we've seen that in this intermediate group, this type of risk predictor is helpful, and studies are now shown that it will reduce the number of events those patients will have if we can identify them.
So that makes sense, because you wouldn't want to necessarily medicate people who don't need it yet. I mean, we hear things now about things like high cholesterol also being genetic. So if there's not any real damage or issue, they might just have a genetic high cholesterol and maybe don't need medication at that point in time.
Yeah, again, if you're genetic high cholesterol, you're going to be treated very aggressively.
Okay.
But if you have maybe a cholesterol that's a little bit borderline, but no other risk factors.
Okay.
So you have no family history, you have no other evidence of any other disease of the heart or the cardiovascular system. In those patients, to treat those patients, you need to really treat a large number of them to see benefit in one. So when we look at this and we try to analyze how helpful a treatment is going to be, you look at the risks and the benefits. And if that patient population that may not necessarily need it, you're giving very little benefit to that group. However, if you're able to identify the group that's at higher risk, then you're really benefiting. And those numbers could be such as, for every 14 that you're treating, you're actually helping one and stopping one heart attack or stroke in those 15 patients. So that's really where you're getting a lot of benefit for that treatment, as opposed to if you treat patients that don't need it, you're not getting much benefit in those patients.
So with these kind of new approaches and advances that you're seeing, how are the outcomes changing?
So the outcomes are changing in that we're seeing less patients having events when they're properly assessed and treated with their risk prevention strategies. Additionally, we've seen that patients that are more involved and understand, they have a CAT scan, they say, well, I feel great, everything, but you had a CAT scan, you show them, look, you do have some plaque in your coronary arteries. Those patients seem to be much more compliant with their medications. I think they feel a lot more empowered, and they feel that this is important to them. So we see a lot better compliance, which also I think improves the results of those patients.
That makes sense. And you hear people say, I was fine, I didn't feel sick at all, I didn't feel bad at all until I had my catastrophic heart attack. So that's interesting, and it's a positive thing that you're able to show them, and they can visibly see where the damage is or what the issue is, and then are better partners in their overall health.
No doubt. I think the patient-doctor or physician relationship, that discussion, being able to understand why you're taking a certain medication is really essential to making sure that patient takes them and understands why they're taking them. If a patient's taking a medication, they really don't know why they're taking it or they don't think it's helping them, I think you're already set up for failure.
Right, and they'll be the one, I don't think I really need this, so I'll just, don't be your own pharmacist.
Very common. They give you a list of 4 medications, but they tell you only take 2 of them.
Well, how is that helpful? Dr. Tino Pena, thank you so much for joining us. Really interesting information, and we hope people do sort of take control and work with their physicians and have positive outcomes in the future.
Great, it was a pleasure to participate in the Cayman Heart Fund.
Thank you.